good afternoon, good evening, from wherever you're calling in from. We thank you so much for joining us today. We will give it just 2 more minutes until others have joined before making a start. Thanks again. Hello again, everyone. Welcome to the 55 or so of you that have joined us. We will make a start in about 1 to 2 minutes. Thank you. Hello, colleagues. Thanks again for joining us. We have about 62 participants online, so we're going to make a start. Welcome again, wherever you may be calling in from. My name is Sarah Hollis. I'll be moderating today's session. We will kick it off right away with turning over to Amarachi, who will walk us through some housekeeping and introduction remarks. Over to you, Amarachi.
Good morning, good afternoon, colleagues from wherever you're joining us from. I'm just going to walk us through a few housekeeping remarks, and then I'm going to turn it over back to Sarah Hollis. WHO is committed to enabling events at which everyone can participate in an inclusive and respectful and safe environment. So even as we ask questions, may we be all respectful, and when we disagree with opinions, may we do this respectfully too. We are also guided by our highest ethical and professional standards, and all our participants today are expected to behave with integrity and respect towards every other person in the room. Next slide. We have interpretation in English and French. If you look at the bottom of your screen, you would see a globe icon that signifies interpretation. If you click on it, you can switch between the languages, and you can also mute original audio so that you can have a seamless experience without interference. You use the Q&A feature. If you also look at the bottom of your screen, you would see a question mark there that has Q&A on it for questions regarding the topic, the presentations, or the technical area that we're discussing today. This helps us to be seamless with answering your questions and also answer all questions without missing anyone. Please try not to put your questions in the chat feature. We use the chat feature for general introductions, like I'm already seeing. Colleagues, you can tell us your name in the chat. You can also tell us what country you're joining us from. And that way we are able to connect with each other. And also, if you are having IT issues, if you cannot hear, if you're having some interference with the interpretation, you can quickly put it in the chat and we will troubleshoot from our end to give you a seamless experience. Next slide. Kindly note that by participating in this meeting as a participant or as a facilitator, we take your attendance as permission to record your contributions and share this recording via various learning channels for continuous learning purposes. So you might find this on YouTube, you might find this on LinkedIn. It is strictly for learning purposes. The session materials, including the recording and some of the presentations, will be forwarded to you in the days following the webinar, including a survey on your webinar experience. And this would help us to actually improve on subsequent sessions. So do well to also fill out that survey. Next slide. Great. If you notice when you were registering, we collected some data from you. Now that all of this data is with WHO and with the Project ECHO, and it's strictly confidential. The data may be used for reports, for maps, for communication, for surveys, for quality assurance, evaluation to inform new initiatives, but that's all. Uh, it will not be used for anything else. Thank you. Next slide. I am now, I'm quickly going to run you through the agenda before I hand over to Ms. Hollis. I have just done the introduction and housekeeping, and my name is Abianura Marchi. I'm a training officer with the WHO African region. We're going to have the welcome and opening remark from our Regional Emergency Director, Dr. Guy Abdul Salam. And then Ms. Sarah is going to take the webinar objectives, and we're going to have Dr. Patricia Ndubi, who is a Technical Officer for the Surveillance and Systems Unit with the WHO headquarters. And then we're going to have a representative from the Kenya Ministry of Health. I think we have Mr. Yusuf Ajak here, who will be sharing AI world experiences and challenges in surveillance systems modernization, and he will also be sharing the experience from Kenya. And then we have representatives from the DHIS2 and the Go Data teams. We have Sylvia here, who is an epidemiologist with the Gowan Operational Support Team. She is also at the WHO HQ. Sarah is going to be moderating the entire session, so she is going to tell us when it's time for Q&A, and she's also going to lead the flow of that session. Our closing remarks will be done by our HIR program manager at the WH African region, and this is Dr. Etienne Kowa. This will be all from me. Over to you, Sarah.
Thank you so much, Amarachi, as usual, and welcome again to all of you. We're very happy to have you here today, and we have a great lineup of speakers and panelists, and we really hope you get the most out of this session. I also just wanted to remark this is a great three-level collaboration where we have colleagues from Kenya, the Nairobi hub, as well as headquarters. So I will just quickly introduce myself, and then I will pass it over to our first speaker who will provide opening remarks. As mentioned, my name is Sarah Hollis. I'm an epidemiologist at the WHO Regional Office for Africa, and I'm based here at the Nairobi hub. I'm very happy and proud to announce our first speaker who will be giving opening remarks, Dr. Abdul Salam. He is the Regional Emergencies Director for the Emergency Preparedness and Response Cluster. Over to you, Dr. Salam, and thank you again for joining us.
Thank you very much, Sarah, and thank you very much to everyone who has joined this webinar and taking part of your busy time to come and discuss about standard. Standard is really important because when we talk, it is about getting together and trying to see how we can do better than the addition of ourselves. When we talk about standard, people may not realize it. Even myself, I was surprised when I saw how important it is when I started back then, a long time ago, my study in biomedical informatics. It was just a matter to play with some words like the concept that you use often, which is a unit of force that can be expressed by term, and it is many terms can really express the same concept. And also the notion of interoperability can't be understood without thinking about the semantic interoperability, but also the syntactic interoperability. And I believe that the semantic one is really very challenging when we talk about public health, when we talk about epidemiology, because usually the data are not the first objective when we are on the field. When we are on the field, the first objective is to save life and reduce pain. and we write only on our spare time to write things as we understand it and using often natural language processing. And as we know, each group has its own natural language processing, has its own way of naming things. So if there is not an organization, there is not a unit that is trying to make a standard where the term and concept are being put together, it is difficult to put them together later. For example, actually, I talk a lot with my team. We have over 70 years of data in WHO, but almost no way it is possible to put them together because when people was using at that time gender, it is not the same than telling gender today. And also when people are using the same term, even in the disease, we say measles, it may not be the same case definition than today. And to that, it is the same language also you're going to see. Even when you go to the hardware, we remember floppy disk, we remember CD-ROM. And I think if you have data on those tools, it may be very difficult for you to just come to my computer today and have some meaningful use to that. So all those need some interoperability, some standard that we need to do. I usually use the term, for example, when you see container being useful, because some people sat down some way and agree on the dimension and on the shape of that container. That's why they can be put together into a ship. And also being trust travel and all those, I think, are very important discussion that that need to be done in health. Unfortunately, in health, we do not do it often. And even the clinicians are doing it more than the public health. So I was really very excited, and I think Etienne has told you, Sarah, when I heard that this is talk about standard. And I believe wherever we are, it is not that is important. What is important is where we want to go and at what speed and what commitment we are ready to put in order to arrive there. So, colleague, I just will be here listening to you and learning again from the great people that you have invited, but also from the great people that have taken their time to come and share their experience. I believe it would be only useful if everybody, over 100 people I've seen connected, are really considering themselves as a learner, but also as a teacher, because it is about community of practice. It is not some people coming and giving the lesson to other people. It is for us getting together and exchanging. So thank you very much, everyone, and have a good seminar.
Thank you so much, Dr. Salam, for those important words. Great way to kick us off. As the slides are pulled back up to run over the objectives, I just wanted to remind and go off of one of the things that Dr. Salam was saying. It's important for the technologists to speak to the public health officers, to speak to the clinicians. And I think this forum is an important opportunity and exciting that we have not only public health professionals, but also we have some software developers and technologists in the room. So we hope that this is the first of many conversations. This is, of course, not the first time we've talked about standards, but I think it is one of the first conversations where we're really going deep in the African region about what is WHO's work on standards, in particular surveillance standards. Dr. Patricia, who is joining us from Geneva, is going to walk through what is the digital adaptation kit? What does that mean? What is WHO's work on it? And really give us an understanding of how we can think of this with our various multidisciplinary professions, and also what's the current stage of development, because WHO has been working on this, and what can we expect in the coming months and year. We're then going to have a really exciting presentation from our colleagues in Kenya at the Ministry of Health. Kenya is really doing a fantastic job in all of their digitization efforts in the ministry, and we're very excited to hear from them about how they are implementing their surveillance standards and actually taking steps towards implementing their DAC. We're then going to hear from a few open source software projects. So many of you on the line might be familiar with DHIS2, SORMAS, GoData. There's many open source platforms that are used across the African region, and we thought it was important to invite these development teams to the table to see their perspective on why these centers are important and how they plan to integrate them into their development roadmaps. Most of all, we would love to have dialogue and feedback from you all on how we can improve the coordination across our countries, across our partnerships, to adhere to these standards, because we will only reach interoperability if we can have more and more people using them, more and more tools adhering to them. So please do feel free to engage throughout the session. Please put your questions in the chat, or sorry, not in the chat, in the Q&A functionality. And we will have, again, that dedicated time at the end where you can even raise your hand and we will call on you directly. So we do hope you learned something new. Thanks again for joining us. And without further ado, I will pass it to our first panelist, Dr. Patricia Ndumbi, Technical Officer at Surveillance System Unit at the Health Emergencies Program in WHO headquarters. Over to you, Patricia.
Thank you, Sarah. Can I just check that you can see my slides in full screen mode?
Yes, perfect. Thanks.
Okay, perfect. Thank you very much. So thanks, everybody, and thanks for the introduction, Sarah. I'm really privileged to be here. So my name is Patricia Dumbi, and I'm an epidemiologist, and I'm leading the Surveillance Data Standards Initiative from HQ. And first, I would like to thank Etienne, Dr. Salam, and Sarah, and Sylvia, and the rest of the Afro team for involving us in this important webinar. And I'm really excited to introduce you to this global initiative, but also to explore how it can catalyze local efforts in the African region. So 2 years ago, WHO launched its collaborative surveillance strategy. And one of the key objectives of this strategy is to support countries to develop and implement integrated surveillance systems. And one of the challenges in achieving this is that the current state is characterized by fragmented and non-interoperable information systems, which capture, as Dr. Salam rightly expressed earlier, different types of data in different formats. So this not only increases the burden and duplication of data collection efforts, but it also delays data harmonization and the generation of insights that can guide early outbreak detection and response. So the Data Standards Initiative really aims to address these challenges by developing terminology and interoperability standards that are tailored for digitalized and integrated surveillance. And this will facilitate system interoperability, simplify data harmonization, and speed up data analysis for faster insight generation and also for better decision-making. So to develop this standard, we are using a framework called the SMART Guidelines framework. So this is essentially a structured approach developed by our colleagues in the Digital Health and Innovation Department at HQ. And it enables us to transform our analog or PDF guidelines that you're familiar with when you download the WHO guidelines online. So it transforms this into a machine-readable technical specifications that can inform the design and the content of digital systems. So this approach has 5 layers, which I'm briefly going to describe. So in layer 1, we have these narrative guidelines, like let's say the latest cholera guideline that you're maybe familiar with. This is then translated into what we call a digital adaptation kit, or a DAC, and this is layer 2. So the DAC is really another document which provides the technical specifications that are required to adopt, adapt, and operationalize WHO guidelines into digital systems. And the DAC is meant to be adapted at the country level. So in layer 3, we basically develop a machine-readable version of the DAC. So this is now software code that can be adopted into various software in a software-agnostic way. In layer 4, we end up with tools such as DHIS2, SOLMAS, and GoData, which we'll hear from some of these tools today, that are aligned with the WHO standards and are interoperable by design. And finally, in layer 5, it's a bit forward-looking because we're not there yet, but the idea is that if we were able to standardize data collection and exchange across the board, this could eventually power advanced or federated analytics models and will provide us with real-time insight to guide decision-making. So currently, our focus is really on the development of the digital adaptation kit, and we'll go more into details in the next slides. So the goal of our project is to develop a digital adaptation kit for infectious disease surveillance, and this will include core disease agnostic components for surveillance, but also disease-specific modules. Version 1 of the DAC will include 4 disease-specific modules, including yellow fever, meningitis, cholera, and measles. And our target timeline for publication is around Q3, Q4 of this year. So we are adopting a very collaborative and iterative approach as we develop this standard. I really like Dr. Salam's point that, we all have to learn from each other. So we didn't want to develop this in silo. We really engaged so many people across the board. We conducted desk reviews, multiple consultations across the 3 levels of WHO, but also external stakeholders. We even launched a global survey, which was responded to by over 180 global surveillance stakeholders, working at different levels of surveillance, global, regional, even subnational. And so far, we've incorporated, very detailed feedback from over 100 of these stakeholders, including disease-specific focal point, all our colleagues at the 3 levels of the organizations, member states, software developers, and also other external partners. So this is really done to ensure that the DAC is not only technically robust, but it is also adaptable and applicable to various settings. So the surveillance DAX includes 8 standardized components, which are meant to guide the development of integrated and user-centric systems. So on this slide, you can see these components. It includes key interventions and recommendations that are listed in WHO surveillance guidance, user personas involved in surveillance, as well as their roles and responsibilities, user scenarios, key processes and workflows, data dictionaries mapped to terminology standards, and it also provides decision support logic, indicators calculation, and functional and non-functional requirements. It's a really massive document, and actually some of my colleagues who are on this call, Kadimul, Abdul, and Nelly, have been working really hard together to build this really massive document that you will eventually see. So, but what I will do is just giving you a snapshot of what some of these components actually look like. So for the data dictionaries, this will be included in the DAC as hyperlinks to Excel sheets. And those Excel files essentially will include dictionaries that define what the core data elements are that are required for surveillance, like the minimum core. But what makes these dictionaries even more useful is that each of those data elements will be mapped to standard terminology codes such as ICD-11, SNOMED, etc. And this is really what will ensure to provide kind of a foundation for interoperability moving forward. We also have the decision support logic table, which essentially provides instructions on how to automate and support some decisions and processes in surveillance. So for instance, this gives instructions to system developers that the system should be designed in such a way that in the case of cholera, for instance, if you have more than 2 suspected cases that are reported within 7 days, the system should flag to the healthcare worker that there is a potential outbreak, and they should guide this healthcare worker on what the testing protocols should be, and telling them, for example, that they need to take a sample and send it for culture, or they need to run a RDT, for instance. And we also have like the user scenarios, and this basically the DAC includes these user scenarios that tells the story of surveillance through real world use cases. So each scenario will capture the different personas involved in surveillance, the patient journey, and the information on the data elements, decisions, and functional requirements that are needed. And it really, what it does, it really helps build a coherent picture or story that shows you how all those components work together to support surveillance functions and objectives. And finally, we have the workflow. This is like last but not least, because this component is really the foundation of the DAC. It's where we started the development process. So once workflows are defined, all other components like the data, the indicators, the personas, etc., they're naturally build around them. So the workflows, they really map out the sequence of activities in the disease surveillance process, and they help visualize how different personas interact with the system, and they guide the data that is needed and the outputs that needs to be generated by the system. So this component is really what guides software developers in translating surveillance processes into digital workflow. And that ensures accuracy, consistency, and public health readiness. So just to end on a couple of slides, just to tell you there's different use cases for the use of the DAC. So when it comes to implementations, there are three main cases. This is important for countries that are transitioning to digital systems because it will accelerate their digitalization journey. It's also important for countries with already existing digital systems because it can then adapt their systems so they're in line with global standards. And even countries that are still using paper, this can also help them run their processes more efficiently. At the country level, what it looks like if you, as a country, wants to adopt the DAC, is that you will basically gather your stakeholders together and review the global DAC and adapt it to your local context. And once you have your national DAC, you can then design solutions based on this or update your existing solutions. And I'm sure some of the presentations will talk to that towards this. And this is my last couple of slides just to say that the DAC is aimed to be published around the end of this year. So we're hoping to stay on track with this considering the current ecosystem. And as Dr. Salam again mentioned, and I really love this introduction because we want to see this as something that yes, WHO can provide the guidance and support for stakeholder coordination, but for this initiative to succeed, it ultimately needs to be owned and driven by the community. So this is why we have established a community of practice, which is going to be a space for the community to have continued collaborations and to do some peer learning together. And I really invite you to scan the QR codes and join this community of practice. We do have quarterly webinars to exchange on experiences and lessons learned. So thanks so much for this. I hope I'm still on time, Sarah. You didn't interrupt me. So thanks again. Over to you, Sarah.
Thanks, Patricia. Very interesting and very exciting that this work is being unveiled. The surveillance digital adaptation kit is really an important area that all colleagues on the line, I hope, can learn more about and make use in their daily work. So very excited next to bring online our colleagues from the Ministry of Health in Kenya, who are doing quite a lot of work in this area. We are inviting Dr. Yusuf and Dr. Stephen. I believe Yusuf, you'll be presenting, and then Stephen will be available for the question and answer session. So please, over to you, Dr. Yusuf. Thanks again for joining.
Yeah, thank you very much, Sarah. And may I take this opportunity also to thank the team for the opportunity. My name is Yusuf Ajak, an epidemiologist and data manager from the Division of Disease Surveillance, Ministry of Health, Kenya. Sarah, is my slide on presentation mode?
No, if you could just click the presenter mode. We're still
Now?
seeing the slide version. There you go. Perfect. Go ahead.
Okay, thank you very much. And I have, as she has rightly mentioned, I have my colleagues, the developer, Steve online, and also I've seen some of the colleagues from WHO country office. So from our side, the challenge which we had was actually pronounced during the COVID-19 pandemic. We had issues with the data management and real-time data management for quick decision making. The country was really waiting for data, and it was specifically at around 12:30 p.m. where the Minister of Health was addressing the nation. So that really exposed the system, and from there we had to look at ways to modernize our data. And thanks to support from CDC, which we helped us come up with a data modernization team, and we have a technical working group to actually look at the data in the surveillance space. So data modernization also aligns with the Kenya Vision 2014 to 2030, and also the goals. And then the issue of the foreign aid disruption is also a big challenge from the Ministry of Health, because we need to ensure that our data collection is actually sustainable because two to 3 months back, the DHIS2 was not working, and we all know what was happening in the global financial space. Then we have embarked on digitization of primary surveillance tool and also interoperability within the other system. Okay. So these are the current challenges and limitation. We have siloed system whereby if this is not checked, you find each partners will come with their own data collection system. We had issues to do with downtime where the system will be down. Then standardization was a challenge for us. You find the variables are actually different. Some will call it gender, others will call it sex. Those variables, you find that you cannot even merge them. Then the issues of technology, we also had issues to do with hosting issues where we find that the data, the partner gives you the system and may at times dictate where the hosting will be. And this one is actually in direct, it's in direct contrast to what the Data Protection Act states in country. As for moving forward, all the data hosted should be, all the data system should be hosted within Kenya. We also had issues to do with the data protection, implementation, and also the unique personal identifier. This is a challenge, but it's a national concern, and I believe we are working on it, and soon we shall crack it. Then we have, through the support from Global Fund, we are working on National Public Health Intelligence System, and this is an overview. It's an Android application, and it's a real-time data. We've digitized minimum tools for real-time data collection and reporting. It's actually built, it's an open source built on Open Health Stack, developed by Google Health. Then we have collaboration with the other stakeholders, and I'm happy to say that as a country, we had the privilege to interact with Patricia and other colleagues who visited us and found us with the working on the DAC. Then the application is guided by the surveillance DAC and compliance and certification. Once you use the Open Health Stack, it's embed all the standards which are required for us. So we've digitized these primary tools. We have AFP's case investigation, AFP contact tracings, measles investigation, weekly epidemiology, all the way to rumor tracking. And you find that one of the major challenges which we used to have is interoperability between field surveillance data and the laboratory. During COVID-19, we'll have a situation whereby the sample is received at the lab and it cannot be directly paired to a case from the field. So this system actually helps us to come up with a way of automating the unique identifier based on the WHO guidelines, the country, county, sub-county, the year, automatically we're able to generate and send a notification to the lab and the required people. So the process, we developed the digital adaptation kit, and it's not simple as alluded by the first presenter, because the decision makers need to understand what we are talking, and you have to make sure that you've broken down DAC to the lowest level for them to understand all those layers. Unfortunately, in country, most of the people will just look at layer 4, the application, but they don't know the process in which has to be undertaken to give you that application. So stakeholders was the most important thing for us we started with. Then we prioritized the tool for digitization. Then, as I mentioned earlier on, it's an open health stack. Then adheres to the MOH Digital Health Agency standard. In Kenya, we have a unit known as within the Ministry of Health, and it's a parastatal, they're known as Digital Health Agency standard, to ensure that all the systems which are developed within the health should adhere to it. We also digitize the surveillance tools and embarked on training on six counties. So I won't go through the layers as my colleague, the former presenter, has actually talked about it. But if I move to contextualize for us, layer one, we've adapted the WHO technical guidelines and we've reviewed ours. We are now at IDSR technical guidelines, the third edition. We looked at it to ensure that the L4 actually speaks with it, what is there, the guidelines. Then we moved to the Kenya Public Health Surveillance Digital Adaptation Kit. That was L2. We had to look at the data dictionaries, roles and responsibility, who does what and at what time, the indicators. So all those things were looked at, and then the developers also translated into machine readable using the FIRE standards, more of like interoperability into play. Then we have this NFIS and it's available on the Google Play Store. So we're still seriously thinking about L5 because we have data and if it's not utilized or if you don't use the artificial intelligence, you find that at times nobody will look at it. So we are still stopping at L4, but seriously thinking of moving towards L5. So this is the application, the mobile first interface, and its compliance with the WHO SMART guidelines and the FIRE HL7 standards. Then the same interface. Then this is the Kenya Digital Health Superhighway. You find that we have disease surveillance. We are part of the superhighway, but for you to be part of it, standard has to be enhanced. We have issues to do with, we have issues to do with standards. We look at the issue of infrastructure, ICT infrastructure, then the data center, then issues to do with the enabling environment, governance, regulation, and standard compliance. Because if you see here, the Kenya Health Interoperability Services actually pushed on us to have a system which will be interoperable. Here you find we have point of cares, we have community health, digital kiosks, other points of source. So the whole idea is that the standard has to be there and the interoperability has to be factored in. Then I'll end with the quote from the former CDC director: data is the oxygen that powers our ability to detect and respond to threats to health. And we are at a pivotal moment in terms of data modernization. With that, acknowledging the team who's been supporting us, and I say asante, thank you in Swahili. Back to you, Chair.
Asante sana, Yusuf. I love that quote at the end. I think I might just put that on my bulletin board. Fantastic presentation and just highlights all of the really groundbreaking work that Kenya is doing. And I hope that other country colleagues on the line can get your contact information, reach out to learn more in detail. I think just to recap, I mean, it just shows the extent of the groundwork that has already been laid by Patricia's team and the DAC, and also work that your colleagues have done with the reference software. So people building applications don't have to go recreate the wheel and look at different workflows or create everything from scratch. It really lightens the load for innovators and implementers to just take something off the shelf that's been validated and works well in line with evidence. So without further ado, and both speakers have been right on the dot on time, so much appreciated for that. I will move along now to our tech gurus on the line. So I said we have both sides of the house. We have the public health officials, and we also have the technology professionals. So we have three groups that will give us a rundown as to how they look at this work. We have DHIS2, SORMAS, and GoData. I will start with the DHIS2 team. We're joined here with a few people from the DHIS2 group, but the presenters are from our HISP groups in West and Central Africa and also HISP Uganda. So we have Jerry Aziawa and HISP West and Central Africa, as well as Immaculate Ayebazibwe from HISP Uganda. Over to you, Jerry and Immaculate. You can take the floor. And just a reminder for anybody that has questions as we go, please do drop them in the question and answer.
Thank you very much, Sarah. Just going to share my slide. A moment, please. Sorry. Okay. So quickly, I'm going to do the presentation, then my colleague will actually complement. So we're going to talk about DHIS2 and how we've been adopting the guidance, WHO guidance, and also doing the digital adaptation kit. I hope you see my screen.
Yes, please go ahead.
Okay, so DHIS2 is a digital public good. It's actually an open source, so it's entirely free. You have license, there's no license fee for that, okay? And then it's kind of generic, it's configurable, it's something that is extensible, and you can actually build interoperability on top of it. Actually, it's used in more than 75 countries, and it's actually an in-country ownership. So we actually build a system that is owned by the country. They will build things from scratch, and it's actually community-driven. So you have a community around the DHIS2 application, and things are driven by the community. So prior to actually our how do you call it, the data of the Toolkit, we actually had a collaboration with WHO Afro and WHO to develop standards actually for packages, and these packages are actually IGSI case-based surveillance. And these packages can be actually used as a reference in countries to actually build from there because we want to standardize, or it could be installed directly. So it actually had some specific components. You have the possibility to, we actually have all the variables from all the WHO Afro recommended variables that were grouped. We had standard indicators. We already had presentations that were actually standardized, and that includes map, chart, tables, and all those things. And then we also had some quality checks already available to make sure that the data is actually of good quality. And of course, it actually is being configured using the best practice that we have based on our implementation experiences. And of course, you can actually install it directly in the DHIS2, but you can also actually make sure that it meets the local workflow, because in some countries, they already have some systems. So, I mean, it's something that could be adaptable. Let's say. In general, we have how to call DHIS2 in a lot of countries. And some countries actually have been using this package for surveillance. So you have Benin, Cameroon, Republic of Congo, Cote d'Ivoire, DRC, Gambia, Mali, Niger, Rwanda, Senegal, that are actually using. Those are the ones that are bold, and they are using our standards. But other countries are also using DHIS2. Basically, what it does is that I'm just going to focus on the case-based surveillance tracker, but I mean, you also have the IGSR. And here what we have is you have some specific diseases that are actually inside that tracker that actually meets the standards. So meningitis, measles, rubella, etc., etc. And then of course, it's actually it's a minimum data set that we have that you can actually implement. Of course, it's adaptable, and you see along the line. And then it was actually done prior to the surveillance data. So that's why you see that it does not include that, or it's not incorporated. But you see with other examples how we can actually work with the DAC. So let's also know that we already have dashboards that are available that countries can use as well. And then, of course, you can actually build on top of it. So, for instance, back then, there was no COVID in the tracker. We added COVID, we added Mpox, and in countries, we actually added new diseases that were relevant to them. So basically, this is how the workflow is. you actually have the case notification, the clinical diagnosis, the laboratory request, specimen tracking, laboratory result, and final classification. So usually that's the way it works. But of course, like I said, something flexible. So we actually make it based on what the country wants. But we make sure that we keep the standards so that this could be used, for instance, in an original instance. And I will talk about the regional instance later. So for instance, this is an example of the digital adaptation kit, whereby we actually were able to add the code into it. So this one's for HIV. So meaning that it's possible. I mean, we've done it for HIV because it was ready back then. But then, of course, we're going to incorporate it for the disease surveillance. But this is, for instance, a dashboard that we have already that takes into account all the indicators. So this is a meningitis example. So what we have is we made the standards available so you can actually have standardized dashboards for decision making. And this is across all the countries that have implemented that. Of course, this is just an example of how we can actually include the business logic into the system. So what the system does is that it gives you information about how to call it the due date based on the initial date. So those are things that are actually already incorporated in GHS so that you can have. Of course, some of the challenges. I think one was trying to adapt the global standard to localized priorities and workflows. So, I mean, it actually requires experts in system design and surveillance because we're having some challenges and also trying to retrofit, meaning countries already had some systems and trying to actually retrofit and make some changes in order to make sure that we are doing the things according to the standard was a bit challenging compared to if you want to do it from scratch. But I mean, it's things that it was challenging, but we're able to do that. And of course, I mean, if you want to add new elements or new how do you call it, standards, it's not that seamless. I mean, there are some times, but of course, we need to plan carefully to avoid disruption of the existing system. And of course, we also had limited resources because, I mean, countries were able to actually sustain the system that we have based on the DHIS capacity that were built across the years, and of course the ability for them to actually design trackers. So this system were actually put in place. So based on that, capacity that we have in country, these systems are sustainable, but then we actually have limited resources in countries. And of course, when you want to implement this kind of surveillance system, then it has challenges with sometimes challenges with infrastructure. Because, for instance, we had in some cases limited internet, we didn't have electricity in some places, and also device management was kind of a challenge in some cases. Then, of course, sometimes you also have challenges with we have fragmented donor support, meaning donors are actually funding or pushing for different platforms. So you end up having kind of a fragmented digital ecosystem. And then, of course, we will call it a pilot fatigue, whereby we actually realize that in many cases, those kind of standards implemented stay in the pilot mode and they actually don't scale up, or there's sometimes a lack of scale up plan. And sometimes it's also due to the fact that there's no fund or leadership. So, I mean, these are actually additional resources that you can use for it's related to GHIS2, where we talk about the metadata packages that we have available, and then we give more information about the standards that we have. And we also have a demo instance whereby you can actually check it yourself and see how things work. With this, I would just say thank you very much.
Thank you so much, Jerry. That was great. We all know how instrumental DHIS2 platform has been in having a standard approach for countries and collecting data and managing health information. And it's great to see all that work underway. One of the points that I'd like to come back to in the question and answer session is this thing you mentioned on retrofitting standards and how that can be more difficult than starting from scratch. But we hope that this webinar shows that it's worth it, even if it's more difficult, and the importance of aligning to the standards. So we'll come back to that, I think. Without further ado, we will have next up, which is our team from SORMAS. We have Jan Bohm, who is the Managing Director of Technology and Operations. Thank you again, Jan, for joining us, and over to you.
Thank you very much for the opportunity to present SORMAS for you today and to report on our activities regarding implementation of the DAX. So I will share my presentation now. Should be able to see it. Yeah, like Sarah said, my name is Jan Böhme. I'm one of the managing directors of the SORMAS Foundation, responsible for technology and operations. The SORMAS Foundation is the responsible organization for maintaining the project SORMAS and align with the community of practice we have around the tool. So first, please allow me to give you a quick introduction to SORMAS, what the system is all about. SORMAS is an acronym. It stands for Surveillance, Outbreak Response Management and Analysis System. It's an open source digital platform that was designed for surveillance and outbreak response to be able to allow everybody who is involved in all the activities to work together in one system. On the bottom right, you can see one of the dashboards that we have in the system that can be used for decision making based on real-time data that is being entered into the system. SORMAS is cloud-based, and we have both a web and a mobile version available. Offline collection of data is available through the mobile application in case there are infrastructure poor settings, for example, where stable internet connections are not always available. SORMAS is recognized as a digital public good. We are currently available in 17 plus different languages, and more can be added through the community of practice. Everything can be translated by people who are interested in supporting the project. It was designed by public health professionals from the ground up, first established in Nigeria together with the NCDC in the 2016 Ebola outbreak. And since then, the project has evolved. Many more features have been added. For example, we are able to do case-based and event-based surveillance. We have a full contact tracing module. On the right side, you can see an example of how the infection chain visualization, for example, looks like. At the moment, SORMAS supports over 40 infectious diseases, but the roadmap we are planning until the end of 2027 is to increase this number for full case-based activated infectious diseases to over 80. We do have a module for immunizations, especially vaccinations and adverse effects following immunizations that can be tracked in the system. The important part is that we do have a task management system that is inside SORMAS. It is connected to every single module that the system has, which is important to keep an overview about all the activities going on at the moment, who is responsible to do what, and you can track the progress that you are making. SORMAS also offers the possibility for geographical and statistical analysis. One example is here on the left side. Those are diagrams that can be created from the system and then exported directly. We do have a full sample and laboratory test result module, which is designed for the case that there may not be a central laboratory information management system available in the country. But if there is one, through the interoperability features we have, this can also be connected to SORMAS to directly feed the data into the system. We have recently added an environmental module and are currently improving on that, for example, with climate data. And also, SORMAS provides a customizable rights and roles system. So every country who is using SORMAS can really make it their own by designing their own roles. What are people supposed to do and what are people not supposed to do in the system, which is also extremely important regarding data protection. We are following the European GDPR as our data protection guidelines. Until now, SORMAS has helped to strengthen the public health system in 10 countries in 4 different continents, over 10 countries in 4 different continents. And just to give you a quick rundown how working with SORMAS works, I can give you an example workflow. So let's assume that, for example, a community health worker receives some information about a possible outbreak. They would then be able to directly create an event for the signal in SORMAS through the mobile application, for example, which then can be investigated. You can document the outcome. At that point, you will see if there are any possible infections, which you can also document in the system. Any samples you are taking, any lab results that are coming in will also be directly in SORMAS. And then you can convert any suspected infections directly to confirmed cases with one single click, so you don't have to enter the data multiple times. And from there, the contact tracing module comes into play. On the right side, you can see how this can look like. So you will be able to directly see in the system in real time how, for example, follow-up visits are doing, where you may need to investigate a little bit further. And for the investigation of contacts and the classification of cases, the system also provides you with guidelines on the case definitions, for example, for the different infectious diseases. Yep, and then basically you will repeat those steps over and over until you've come to a conclusion on a possible outbreak, or the outbreak has been contained. So when implementing the digital adaptation kits into SORMAS, there are a couple of challenges. They are very much alike to what my colleague from DHIS2 showed you earlier. So for some infectious diseases, the digital adaptation kits have not yet been finalized, which means that we have to go back after the fact, after we have implemented a new disease, and maybe adjust it to the digital adaptation kit. This is just something that is quite normal, and we just need to work with that. A little bit more complicated is the mapping of the data that is included in the digital adaptation kit to possible legacy data that is already in place in the country. So those do not always match up perfectly. And it also can be that a country already has specific regulations that directly contradict, for example, proposed processes in the digital adaptation kits. And this is where we are trying to work together with the country and WHO and our development team to somehow find a solution that is the best fit for that for that situation, basically, in the country. Also, there's only limited funding available currently for the DAC implementation. We heard earlier from the example in Kenya, for example, that it is not always visible how much work goes into implementing a digital adaptation kit into the actual software. The only thing that people see is the outcome, how it looks like, does it work, does it not work? But all the work that has to be done before is not that prominent, so it is kind of hard to find funding for that. And for us, it's the same. Sometimes implementing countries may just get stuck in a pilot phase because there is no further funding available to scale it up. Our DAC-related activities currently for the roadmap that we are planning is until the end of 2027. We will use the DACs that become available to inform the design of new infectious diseases. We are currently working on tuberculosis, and HIV will be the next one that should be implemented. We will keep aligning with implementing countries if there is any need to adjust processes, for example, do data mapping. We try to raise awareness about funding opportunities with different countries. We will keep supporting the open source community around the DACs and open source surveillance systems in general. And by the second half of 2025, we will start activities to implement the data standards for interoperability, as well as see if there is any need to refactor our current data model to align with the digital adaptation kits in the future. And yeah, with that, I would like to once again thank you for the opportunity. If you want some more information, you can either contact me directly or you can go to our website, somos.org, or the public demo system that we have available at demo.somos.org. Thank you very much.
Thank you, Jan. Very interesting, and we're grateful for all of the work that SORMAS is doing in this area to push it forward. So let us hear from the third tool that we'd like to highlight in terms of open source project adhering to standards. Sylvia, over to you. We'd love to learn more about the GoData tool and the work in this area. Thanks.
Many thanks, Sarah, for the introduction. I'm going to start by sharing my screen. So that, okay, can you see my presentation?
Yes, perfect. Go ahead.
Fantastic. So I'm Silvia Morreale, an epidemiologist, and I'm part of the Core Operational Support Team. I have been supporting this project since 2022. And for today, I wanted to share with you some reflections on the use of the GoData to support DAC implementation. So for those of you that are not familiarized with this tool, GoData is an innovative open source software that was developed by the WHO in collaboration with GORN partners. It is an easy to use and user-friendly tool which facilitates all aspects of the outbreak response. It has been specifically designed to allow field users, and for field users, we're referring to epidemiologists, contact tracers, to register cases, contacts, and the related data. GoData also provides, as you can see on the right-hand side of the presentation, a series of outputs and visualization of trends of transmission, which supports responders to take timely public health measures in response to outbreaks. This application is highly configurable and easy to adapt for a wide range of scenarios and contexts. So I wanted to highlight just a few features or key features of this application. So this application can be used both online and offline on multiple platforms: Windows, Linux, Mac, iOS, and Android. It is possible to modify the existing software language, but also to add new ones. It is highly configurable with configurable location data and variables, and it has an extensive number of features that allow to import and export data. It has also a mobile app, which is mainly focused on field work, contact tracing, and case investigation on the field. So, but in addition to these core features, GoData includes specific sections and functionalities designed to support the integration of recommended public health practices and data standards. And in this sense, one of its key strengths is that the application was developed based on extensive experience of WHO and its partners in managing public health emergencies, and through the incorporation of all the lessons learned from field implementation of data collection. So in other words, this application was designed intentionally to align with and support all the outbreak response processes and workflows through different sections. So it supports the workflow during an outbreak response. So it has a case investigation and monitoring module. So here on the right, we have a graph that summarizes a bit like the different steps of the response. It also contains a contact identification and follow-up modules where teams can actually follow up daily or how they are setting the application, the contact status. And it also provides different features for data visualization and analysis, as I mentioned before. Here, in particular, it has built-in dashboards and transmission chain visualizations, along with a series of KPIs. Here, GoData allows to modify the threshold, but it does not allow to incorporate new indicators. So maybe when there are some specific recommendations to DACs for disease specifics, these can be addressed through connecting Go data to external tools through its open APIs, such as R, Python, and others. So it's a possibility of adding this, but not directly into the application. So this may be a challenge for some users. So by having these sections, GoData can support the incorporation of all these recommendations, but also one of the things that I wanted to put as an example is that since the application was developed, the GoData project team has been working closely with different teams within WHO in the creation of what we call WHO standardized outbreak templates. And what they are, well, they are simply pre-configured outbreaks that are based on the most up-to-date recommendation and guidance. And by using this template, a team can set up an outbreak within minutes, and they have the benefit of offering a standardized investigation form for cases, contacts, lab, follow-ups, and also a standardized variable coding and reporting data for easier analysis. It also offers some preset targets for priority indicators. As I said, we can modify the threshold, but not to add new ones. And then currently we have 10 outbreak templates, and we are working with teams to incorporate new ones. On the right, you can see the list of the diseases that we currently have. And for all of them, we have developed a series of data dictionaries, and metadata overview that support teams to better understand and to map what we have with DAC. So other aspect of the tool that can be used to support the implementation of DAC is the possibility of mapping personas to the digital roles within GoData. So GoData offers flexible user role management, allowing outbreak response teams to align the platform with the real-world responsibilities of different team members. Basically, once the responsibilities are defined, implementers can use one or more of the 3 default user roles that you can see here on the right, or even further customize it or create new ones. And in addition to that, and here's an example that I put on the right, we have a series of guides which support teams to better understand how to use the roles and how to assign them during a specific outbreak. So this flexibility allows GoData to accommodate both standardized workflows and the distinct structures of national and local response teams, enhancing clear data ownership, access control, and operational accountability. So moving to the GoData core and custom data set, we can say that the application provides the full core data set and reference data for these different entities, cases, contacts, and so on, but also allows users to customize this core data set and to include additional variables. So this particularity, combined with what I mentioned before on the standardized templates, allows the team to easily adapt the application to their specific needs. And if there is a change in the recommendations, this change can be directly made by the user without needing to have like coding skills. So this can be really done through the user interface. And here maybe I can mention that we also face, related to these forms that are used for case investigation, same challenge that was mentioned by the other teams, where there is a kind of different priorities between what is suggested by WHO and the countries. So most of the countries define which is the form that they want to use according to their needs. So finally, I would like to take just a minute to talk about interoperability, because this for us is essential. GoData is an outbreak response tool. This means that we don't use it on a daily basis. It is only used when there is an outbreak. So being able to talk with other systems is essential to avoid the creation of silos, of fragmentation, or duplication of the work. So in this sense, GoData provides a robust APIs to enable seamless data exchange across digital health systems, supporting national and interoperability goals. And we have multiple experience from different countries. GoData during the COVID was implemented in more than 65 countries and 115 institutions. And with the ones that we had the privilege that we work with and support, they have created or either ad hoc middlewares to connect GoData with HS2 or other tools. And also, his Uganda team that is also present today have developed an adapter that allows to connect Go data with HS2. And there is another team also that work on another adapter, both free and open source, to connect Go data with SORMAS and HS2. So all these options are available, and we share all this information in our GitHub. So if we think of data within the DAC umbrella, we can think about this tool as a specialist outbreak module within the broader national digital health infrastructure. So finally, I would like again to echo the challenges that previous colleagues have mentioned, but also to highlight that making all this effort to implement the DAC within the table, within the different tools, has a series of impact and benefits. And within them, we can say that it enhances, or what we have seen, it enhances some of the areas of impact that the application already has. So I just mentioned these 5 as some of the key ones, which are related to improved timelines, data quality, access to case and contact data, automated and improved visualization and analysis and reporting, and reduced number of disconnected data sets. So it is an effort, but we think that it's actually worth it. Finally, here we'd like to share some resources where you can have access to our different case studies, use cases, where you can learn more about different experiences in implementation of the tool. And here, the places where you can find documentation, templates, and the different things that I was mentioning during the presentation. So that's all on my end. Thank you very much.
Thank you so much, Sylvia. Great work. And I just hope everyone sees the trend here. We're not recommending one specific tool or not suggesting that one tool can be possible in every setting, but rather showing that there's many tools, but they have commonalities of kind of 2 main things. All of them are open source, and all of them are adhering to standards. So this is why we wanted to start this conversation, and really, hopefully, it continues offline as well as you all connect more and more. We've reached our Q&A section of today. We have plenty of time actually to do Q&A, so please do raise your hand if you'd like to come off of mute and ask your question directly. I believe if you raise your hand, then we can make you change your privileges to where you can come off of mute. But while you're thinking, I will just look through the Q&A and see what we have so far. So there's been a few questions to the Kenya team on their mobile application and how data privacy and security is managed. There's been an answer already from Stephen there. We have some questions around how country focal points can learn more about the DAC work and how to actually develop guidelines in that domain. Maybe I pass this one to you, Patricia, in case you have any resources to point to in terms of how focal points can be trained on how this really works in more detail.
Can you hear me? Okay. Yeah. Can you hear me?
Yes, perfect.
Okay, sorry. So at this point, what we're doing is basically organizing webinars like what Sarah has invited us to, so we can create awareness around this. In terms of like specific training on how to implement a DAC, we haven't developed one, but I believe that the Digital Health and Innovation Department is actually working on a smart guidelines training curriculum to develop something that can be rolled out to countries. I don't know what's the status of this curriculum, but I know that that's something they're trying to standardize and put together. For us, right now, our energy and priority is really focused on at least getting that first version of the DAC out. And after this, like we want to do some pilot countries in specific countries, and I think there's going to be a lot of lessons learned there in terms of how to tailor, future trainings that are specific to the surveillance DAC. For instance.
Thanks, Patricia. There's been another question from Salyu. To what extent are AI tools and advanced analytical software, for example, Python, R, Stata, being incorporated into the development and enhancement of your platforms? That's a great one. So this is for really all teams on the line, DHIS2, SORMAS, Go Data, So maybe Jerry, Jan, Sylvia, indicate if you'd like to comment on this. Really feel free to take the floor.
So for SORMAS, for me, this is always a big dream of mine to somehow at some point have AI supported decision making in SORMAS so that the system would be able, for example, to predict possible outbreaks in the future. So you're already able to prepare for everything. That being said, we are not there yet. We are currently investigating how AI could be implemented into SORMAS, also especially in regards to the highly confidential type of data that is in the system, how it can be used to even train a model, for example. But that is where me personally, I would like to see SORMAS at some point in the future.
Okay, so we'll check back in next year or two and see where we're at on that wish list. Okay, Jerry, I see you come off of mute. Do you have anything on this?
Yeah. Yes, I mean, I actually did say in my presentation, the answer is quite extensible, and I think we've actually have some exploration regarding AI tool and actually bring advanced analytical tools into the use of the whole DHIS tool. For AI, I know that some countries or HISP actually have developed some solutions, just that they are not actually public yet, but maybe like in a couple of months, we will actually have more, how do you call it, solution regarding AI. But I have my colleagues here, Rebecca, Emma, that can also complement over.
Thank you. I see Rebecca typing. I'm not sure if she's able to come in and speak. I'm not sure how to activate that. Oh, there you go. There you are.
I certainly
Rebecca, over to
can.
you.
Sorry. I
Great.
think you described it quite well, Jerry. And I think with AI right now, I think we're looking at two really big things. I mean, one is the way that we are also working internally and incorporating AI just into routine practices. So sometimes this is about making things like data capture easier through processing of images and text and pipelines into DHIS2, trying to overcome just those traditional barriers. Another really big way that we're trying to work with AI and DHIS2 is connecting with a new piece of software we're supporting. That's really around connecting with modeling, predictive modeling, AI, and machine learning solutions. And so I can also type a link to some of that work into the chat. While I'm also chatting, Sarah, just while I'm here, I was also typing a response around sort of the interoperability question. And we worked quite closely, DHIS2 and the Go Data team, also with strong support from Sarah and WHO, on some interoperability solutions that were grounded in the Ebola response in Uganda, where Go Data was really being used actively to manage and contain that outbreak. But a lot of this data really also is being collected and managed holistically in the national EIDSR, which is DHIS2. So we some solutions there, but there were key learnings that the tools and the interoperability itself was not always the challenge. There was also those levels of governance and having shared district lists and things that are quite important as well to have in place for these tools and interoperability solutions to work.
Thank you, Rebecca. Yeah, I'm getting a flashback from our Uganda discussions. Over to you, Sylvia.
Yes, many thanks. I'm going to comment on the 2 points with regards to incorporating some of these AI tools is also a dream, and it is in our wish list. And we also have this idea of being able to incorporate AI tools so that we can use these the AI to identify trends or potential clusters that were not identified in the data. So that was something that we wanted to do. What are we doing though is we are working with the Liverpool University in trying to understand how AI can be used to support contact tracing activities, in particular when there is a high number of contacts that needs to be followed. So we are working on that aspects. So that's something that is happening now, maybe more to come by the next year. But yes, with regards with incorporating AI tools and advanced analytical software, that's something that is also in our to-do list, and we hope we will be able to work on that in the future. With regards, I think there were some questions on use cases. I'm going to share, but I don't know why the person that was responding disappeared. I will try to find her again, because it was asking about some use cases. We have a report that we have done with Sarah when we were both at the HQ, where we documented a number of use cases where this interoperability was done. There's also a publication that was done by the Ministry of Health in Uganda where they mentioned this interoperability. And there's, I think, a number of publications where this is documented. I'm going to try to identify again the chat and paste all these links there. Thanks.
Thanks, Sylvia. We have Yusuf and Jerry, so I'll pass it to Yusuf first and then Jerry.
Yeah, thank you very much, Sarah. I just want to make a clarity. One of the questions was asked the challenge which we had with the DHIS2. It's not the DHIS2 as the solution itself. We had the issues. That is the time we had the work stop order from the USG, and our technical arm for DHIS2 is Health IT, and they were supported by USID. So that affected us. And they said if it rains heavily. That was also the time we did not pay these hosting services, and the provider on the other side had to switch off. So it's not DHIS2 per se. Then somebody also asked about data security, how we work on it. We have semi-autonomous government agency known as Digital Health Agency. They actually look at the solution if it conforms to the standards and regulation of the country. Then we also have the solution will be subjected to data protection impact assessment. Then in terms of hosting is now a requirement. All the data will be hosted within the servers in the Ministry of Health. And then we have issues to do with those who will be sending data to the system. They need to be registered, all those kind of things. So those are some of the layers which we have in place. Thank you, and back to you.
Thanks, Yusuf. Really helpful remarks. Jerry, over to you.
Yeah, sorry, maybe I mean to answer the question, I was more thinking about the surveillance. But we actually use AI tools for climate health. So actually we are using it now to actually predict how the possible cases or potential outbreaks of malaria, for instance. This is helping in Togo. This is a live case whereby we actually use that to predict where we can have SMC campaigns and so on and so forth, based on the AI tools. So something I haven't mentioned, but I mean, we are using AI to not maybe in the surveillance domain now, but yeah, it's in other domains. Over.
Great. Thank you, Jerry. I don't see any other questions at the moment, but I might just remark on one of the interoperability questions and actually thinking back to the Sudan virus disease outbreak example. When we were sitting down with HISP Uganda to work out what that integration would look like, oftentimes the major blocker was at the step one of which area is the data being collected first. So DHIS2 was utilizing the health admin levels, the health facility tree, down to the smallest health post, whereas the contact tracing tool GoData was at the community level because the CHWs were organized at the community level and not at the health facility. So it was sort of this first level disconnect where it was tricky to understand how we solve that. Do we change the DHIS2 tree to have the community? Do we map several community areas to one facility? So it's actually just thinking through of like the purpose and the end user and the actual granularity of the data collection at the first point of entry. I don't necessarily have an answer to the question, but that's also something interesting, I guess, to think through of. And I'm not sure in the end what ended up being the solution with HISP Uganda. I would be interested to follow up on that and learn more. We do have maybe time for one or two more questions. I will just see if there's any others in the chat. Otherwise, we can pass it to our closing remarks. I don't see anything at the moment. I will just open up the floor one last time to all our great panelists. If you have anything to end with or final remarks before we pass it to Dr. Kua. No? Okay. Thank you so much again, everyone, for joining and sharing your experience. We will now pass it to our program area manager for health information risk assessment. So all of this work at the Regional Office for Africa is under the leadership of Dr. Etienne, who's really steering us in this direction. So I will just pass it over to Dr. Kua to give us some closing remarks before we sign off. Over to you, Dr. Etienne.
Thank you very much, Sarah. Let's increase a little bit my volume here. Okay, thank you very much. I think this has been a very important webinar. I first want to thank all the organizers, Sarah, Patricia, and others who worked to really put everything together for this very, very useful webinar. When I look at the participation list, we got over 180 people participating, which is really a great number. But also a very, very diverse participation list. Looking at the profiles, basically, I recognize people from the ministries of health, also from other organizations. We have a technology piece, which was very important. The presentations were really excellent. And the discussions were so important, and I'm sure we'll have to follow up with many other questions, particularly those last points on the AI applications. So when we talk about data standard, and I think from the opening remarks, you notice how much it's important from what Dr. Salam said. The key word here is really the integration. So how do we communicate between systems? How do we actually implement interoperability? There was a very good example of looking at those silo systems and how even capturing data is difficult from the definitions of the indicators, which of course sometimes are different from one system to another. So we all recognize the importance of this work, which has to be strengthened. But as we move on to strengthening collaborative surveillance, I think the keywords of integration will become more and more important. So how do we standardize everything to understand how we are going, how we're integrating data, not only in our health sector, and not only in One Health, which we are getting used to it, but beyond those sectors, going to other sectors such as education, transport, and others, and how much those sectors have been actually implementing the systems to be able to align and integrate data points or pipelines into the greater surveillance system. So just to say that this was really a great opportunity. Of course, there will be more and more communications, and we hope to have more webinars moving forward. The example of the collaboratory that Patricia mentioned, I think was really great. How we build on communities of practice to really strengthen what we are doing is a very important area. And I'll end by saying that AI is becoming more and more a way to go in many sectors, and how much we can leverage AI to help understand data systems throughout, and it was also helping with the alignments would also be important. So I really appreciate the interest in touching on that particular point in the end, and how much we can really integrate that into what we are doing. There is a whole component of surveillance, which is now really looking ahead, looking at how modeling can help understand what is going on and not waiting until things happen. Is also a very important area, and how much this data alignments standardization can also help will be important moving forward. I really appreciate this technology part as well, looking at what SOMAS is doing, Go Data and DHIS2, and how much countries can learn from. I think these presentations were very good for many people who hear about these systems but have not seen those, particularly those that we don't use in more detail. I thought was really, really, really important to have those slides. And hopefully when the slide gets shared and the links, the resources that were also mentioned would be very useful for everyone. I want to end here and thank again everyone for your participation. It was very active. I was looking at the chat, it was very busy. So thank you everyone. And let's continue the work and plan another session with more details. Thank you, everyone, and have a great day.
Thank you so much, Dr. Thanks. Thanks again, everyone, for joining. Bye-bye.
Thank you so much. Bye-bye.
Anything?
Bye.
Bye.
Bye, yeah, bye everyone.